doing so. I'd like to introduce Tony Martinez, who's going to give an experience along those lines. So Tony Martinez is a hepatologist at the Erie County Medical Center in Buffalo, New York. And I believe this is the first talk with us at the Coalition. So thank you so much, Tony, and over to you. Appreciate it.
Thank you very much, Neil. This has been great. Some great presentations. It's an honor to be a part of this panel. So I'm going to walk you through our model here in Buffalo, a clinic that we call La Bodega. And I'll give you a sense of kind of what we do and where our women of childbearing age fit in. But just by way of context, when we think about Hep C elimination, I always think about this with 4 key pillars. So there's screening, linkage to care, and then treatment initiation. And the goal is obviously to hit 100% of each of those 3 steps in the cascade. And the fourth pillar for elimination is really harm reduction. And the goal there is to prevent both new infections and also reinfection. So in order to achieve, 100% in those first 3 and to keep that 4th pillar rates very low, it's really a mixed and matched approach. So one size doesn't fit all when we're looking to carry these things out. And really, our approach depends on the population of patients that we're trying to serve. And it might look different for each one of these groups, and that includes women of childbearing age. So a lot of what we do depends on the setting in which we're doing it and what resources these settings have, or what resources, just as importantly, that they lack. And it really depends too on who's doing this kind of work. So, we know that we can do hepatitis C care in a number of different settings. We've decentralized it away from specialists, and we've moved it into other locations like substance abuse clinics, for example, or FQHC's mobile units. A lot of these places may be able to screen, they may not be able to screen, they might have point of care tests, or they can do reflex testing. And this includes a lot of the OB practices that we see in our area. They have variable resources. They have, these women are being seen in a number of different settings. And there's a mix of providers. A lot of these programs are NP or PA led. There's a lot of midwives that are now involved in this kind of work. So these are important groups that we have to engage to really carry this stuff forward. How we treat people, there's a number of different modalities. So we can use conventional referrals, but the system, at least here in the States, is very difficult to navigate. It really requires a multidisciplinary approach, and things that can make that work easier are things like case managers or peer navigators, but that system can be really complex. More and more, we've utilized telemedicine, especially during the pandemic. This has been more widely deployed, and this is very useful because we can link people in any kind of setting. It's very convenient for the patient. There's pluses and minuses to it. In our own experience, it really slowed down the cascade for what we're typically able to do in a couple of days. Telemedicine would take 30 or 60 days to carry out to get people started on therapy. And then there's finally co-localization, and you started to hear a little bit about this, but this is one-stop shopping. All of the services are offered in one location. It streamlines care. It really minimizes loss to follow-up. So you've seen some data about Hep C and women, and we've seen a clear skewing in the demographic of who has Hep C, especially within the US. The population, the baby boomer population got a lot of attention for a long time, and it's still an important population. We as Rachel pointed out, we have states that have had restrictions, and some still do. So we still have a lot of baby boomers who haven't been treated. But what we've seen is that most new infections are occurring in individuals who are under age 30. And not only is the demographic skewed younger, but we've seen a gender skewing as well. In the old days in the US, Hep C was primarily about 3-to-1 male to female. And what we see now is almost a 50-50 split. And in my own practice, it's about 50-50 right now. So we have more women who are at risk for acquiring Hep C, and they're starting to come into care more. We've seen some data about the changing prevalence among pregnant women. The rates on US birth certificates, they've gone up almost 90%. From 1.8 to 3.4 per 1,000 live births. I work a lot down in Appalachia here in the States, and the rates there are extraordinarily high. When you look at infants born to Hep C positive women in Kentucky, for example, the rates are 1 in 67, and comparatively in the rest of the US, it's 1 in 308. And we have a lot of data about vertical transmission risk. We know it's somewhere between 6 and 7% in mono-infected women. In women with both Hep C and HIV, goes up to about 11%. So this is a group that we're really concerned about, and we're seeing more and more come into the clinic. Now, the Bodega is it's a hospital-based clinic in an urban high-risk setting. And we get a lot of questions. Is it a hepatology clinic? Is it an addiction clinic? What is it? So I'm trained in both hepatology and addiction. And the answer is it's whatever the patients need it to be. So for some individuals, they may just need, Hep C treatment. They may need, cirrhosis management or whatnot. For some, they may be coming simply for the addiction management. But for most people that are coming through this clinic, it's a combined co-localized approach to both things. This is just a couple pictures when patients get cured. They leave messages on the wall. They ring a cowbell. It's really kind of a cool little setting. So the way this works, it's a hybrid program where we rely on the conventional referral system, but then we also utilize telemedicine, and the backbone of the program is really co-localization. So for 20 years that I've been doing Hep C work, we've always asked, where are the patients? How do we find the patients? And we know where they're at. They don't access care maybe in the conventional settings that we're used to. But we know that they're in community addiction practices, syringe exchange programs, high-risk OB, or high-risk pediatrics, the foster care system, then the usual prison, jail, STI clinics, the ERs. So we partnered with all of these sites. And I showed you before that mixed and match approach. Not every one of these sites can screen the same way. So what we've done is given each of our partner sites an individualized modality to screen. So whether it's a point of care test, or if they can get reflex testing, that's great. If they can't, it's a conventional antibody test. And we've really, specifically to women of childbearing age and pregnant females, we've worked hard with our local OBs as the screening guidelines adapted to universal screening of all pregnant women at the time of each pregnancy. We started to engage more and more with that discipline. And we've seen the rates of screening definitely go up. It's not perfect. It's not 100%, but we've definitely seen the screening rates rise. So once they find positive individuals, we've made it really easy, not only for the patients, but also for the providers. There's not a lot of additional labs that we require. If you have a positive antibody test, that's enough for us. There's one number, one email. We get the patient's name and demographics, and then our crew kind of does the rest. We navigate the system both for the patient and the provider. So we arrange, the link, we arrange transportation, the scheduling, we contact the patient, and all of this happens very quickly. When patients come into the clinic, it's a co-localized approach at that point. We have an on-site lab, we have an on-site pharmacy. Patients can essentially be evaluated and leave with medications nearly on the same day. There's also co-localized MAT, PrEP services, HIV services. So this all happens right there on site. Then there's a minimal monitoring approach. There's no additional labs. Most of these patients are on some form of MAT, so we're seeing them frequently, usually on a monthly basis. Now, the way we handle each patient, we have this triage system, red light, yellow light, green light. And this helps us to decide, what level of support does a patient need, and especially with medication handling. And, the first step is to ask the patient, what do you think you need? If you want us to handle the meds, have them delivered to us, we'll do that. Now, I get asked a lot, what are the metrics in each of these categories? And, there's still a little bit of art to medicine where you have to kind of identify with your patient and make some judgment assessment on where they're going to fit in this scheme. So a green light patient is somebody who's maybe employed, has a vehicle, they came to the first appointment, they have, the same phone number, stable housing. That's somebody that needs minimal support. We could give them all their medications, they'll be fine. Somebody who falls into that yellow light category might need a little bit more support. Maybe they miss some appointments. We know if they have the medication, they'll take it, most of the time and be okay, but maybe they need extra support to get the refills, for example. they might need more frequent reminders. A red light patient is somebody who, we have to do everything for. We have to handle the medicine, parcel the medicines out to them, frequent reminders, see them more frequently. So that's kind of the system that we use. And the model really works because we're navigating the system for both the patients and the providers. You have to meet patients where they are, but you also have to meet providers where they are. It's a small hand-picked team. And like I said, we take this mixed and match approach. So when we look at our data from the active PWOD, or people who use drugs, this is data only through 2020. And this number now is closer to about 2,000. And you can see whether we use an 8-week or a 12-week regimen, the adherence rates were 91%. The overall SVR rate is 94%. And the rates of reinfection are pretty low at 1.4%. We do about 8,000 visits annually. We have an 80% show rate. There's no incentives in this clinic. There's no incentives to come. And there's an 85% rate of retention and care. So we're able to follow these patients, long-term. And in patients who come in that have not initiated OAT or MAT, so far to date, there's been 100% uptake in that. Now, included in this group is this cohort is part of the PWOD category, was our females in the 3rd trimester of pregnancy. So I've only included that data here. Some of you have seen a version of this that we showed at ASLD this past year, but this is the updated data that we have so far. So amongst our 3rd trimester females, we had 20 in total, 2 of whom we treated with Harvoni. They both achieved SVR. 2, we started treatment with Epclusa. They're on treatment currently. We had 2 individuals who started on Epclusa, but those 2 initiated treatment and then they were lost to follow-up. We were able to confirm that 1 achieved SVR and 1 we don't know the outcome. We had 5 females that were referred in that 3rd trimester that failed to link. They didn't show for the first appointment. So you can see that's definitely a gap. That's a fairly large number of individuals that we need to do better to make sure we facilitate that link. 3 females were referred in with a positive antibody test because that was all that site, the referral site, could get. And when we checked their RNA, it was negative. So they were spontaneous resolvers. There was nothing else to do. We had 2 females who elected to be treated postpartum. They wanted to wait. They both achieved SVR. We have 1 female who was prescribed medications, but her addiction was really kind of the priority. She was, a lot of things happened in her life and are still happening. She never started the meds. She ultimately delivered the baby. So far, there's been no evidence of vertical transmission. She was prescribed meds, received them, but never initiated them. We had 1 individual who wanted to be treated, but the insurance denied it. She was lost to follow-up and she was ultimately relinked, but it took about a year to get her back. We had 1 other individual who was evaluated. She went through all the steps, but then was lost to follow-up, and 1 who was evaluated and was incarcerated before she was able to initiate treatment. So we have extensive harm reduction measures. Every patient that comes in, including our pregnant women, they're provided Narcan, they're given safe use kits, fentanyl test strips. All the patients all get our cell phones, our emails. We're really embedded with this community, and this clinic is really a safe space. There's a lot of trust. There's no stigma. And I think that's one of the keys for why they continue to come in at such a high rate. We've done some other stuff that extends beyond the 4 walls of the clinic. We have a mini residency for addiction medicine providers. This rotation is mandatory for all of our GI, ID, and addiction fellows, internal medicine and family medicine residents. We've started a program where we screen all the children of our Hep C positive moms, and then in collaboration with family medicine, provide treatment for those 3 and up. And we've implemented universal screening in the foster care system. So we know about 50% of these kids go into the system, and in collaboration with pediatrics, we now have implemented this countywide, where all of these children are able to get screened. That's our crew, and thank you very much. That's all I have.